Okay, we're at the top of the hour, so we're going to get started with our webinar. Welcome to everyone. This is our ASPPH Presents webinar, What does the U.S. presidential election outcome mean for public health? Before we begin, a reminder that you can ask questions in the Q&A button at the bottom of the page, and that we will get to those questions at the end. I do want to also say that there are some reporters who have signed up for this webinar, so it will be on the record. We're super excited about the number of people who've registered for this webinar, and we'll also look forward to those who will see it later when the recording goes up. I'm Tim Leshin. I'm the Chief External Relations and Advocacy Officer here at the Association of Schools and Programs of Public Health, or ASPPH for short. And we have just a great panel for you today. And I want to quickly introduce them, and then I'm going to say a few remarks. So we have Megan Messerly, politics reporter for Politico. She's just back from covering the Kamala Harris campaign. Mark Miodesky is the principal director at Cornerstone Government Affairs, which represents ASPPH in DC. I always say that Mark is the public health policy whisperer. We also finally, but not last, we have Dr. Khan. Dr. Ali Khan is the dean of the University of Nebraska Medical Center, who is an ASPPH member. Thank you, and also serves on our board as our treasurer. And he served for many years at the Centers for Disease Control and Prevention. So we have a great group to talk to you. Before the panelists start, I just thought I'd give a brief perspective from ASPPH about the election. I think we can safely say that polling may be dead, in the sense that while everyone, a lot of people might have predicted that Donald Trump might have won, I don't think anyone thought we'd know the next day. It came by much more quickly than anybody expected. And given the Trump's first administration and the work on things like COVID and his willingness to quote unquote go wild with RFK Jr. going wild on health, I think we're in for a bit of a bumpy ride here for public health. But that doesn't mean that we won't be able to engage and work very hard on public policy related to public health. As we're looking forward, we also see that the Republicans have gotten the trifecta of probably keeping the House, taking over the Senate, of course, the presidency, and not to mention the Supreme Court. So maybe that's all four. So all that said, the Association of Schools and Programs of Public Health, we're really committed to our values and our mission that we've always had around promoting academic public health. And we believe that there is some real potential here to continue to advance and promote public health and academic public health in particular. But we know we'll also probably have to push back against certain threats to public health. And that's our job. That's why we're here, and why we represent the 153 schools who are our members across the nation, across the globe, is to promote academic public health. And so we will be working with many of you to continue our mission related to advocacy and public policy in this regard. And we're really fortunate to have a great group of folks here to talk about the next steps. So now I'm going to ask Megan if she will provide her take as a journalist on the potential impact of the election on health policy. Megan?
Wonderful. Thank you so much for having me. Jumping off of Tim's comments, I mean, I think we're in a place that a lot of folks didn't expect us to be. I don't think we expected to have a result until Friday or Saturday like it was in 2020. And so Here we are, 7 days after the race was called, and President-elect Trump has already started announcing vast swaths of his cabinet. We got a flurry of announcements last night from him. So I just think we're in a place where things are evolving and moving very quickly. Everyone sort of knew going into the election that, we could sort of have a variety of unpredictable outcomes. But still, I think the decisiveness with which we saw the election called, and then the decisiveness with which the president-elect is moving to put his agenda in place is quite striking to a lot of folks that I'm speaking with. So jumping off of Tim's comments, yes, we're heading into a situation with a Republican trifecta, which obviously has vast implications for health policy and public health policy in particular. It just opens up the number of avenues that the president-elect has to advance his agenda. But that sort of gets to the question of what is his agenda on health policy. One of the things that I've been talking with folks about is healthcare was not a top issue on the campaign trail, which was just such a departure from 2020, in which COVID was at the heart of everything, right? I remember being at the Democratic National Convention this summer and no one was talking about COVID. Very few people were wearing masks. It was just such like a starkly different situation that we found ourselves in from the one we were in 4 years ago. So, we had now President-elect Trump talk about, concepts of a plan for health reform. House Speaker Mike Johnson has promised massive health reform, but we haven't seen really many details, right? There's been a lot of different, Republican allied groups working to put some of these policy proposals together, but ultimately we don't know what the president-elect supports. He just hasn't weighed in on that in that much detail. And ultimately, a lot of this is going to depend on the people he appoints, and that's something we're still waiting on, right? We got quite a few announcements yesterday. Defense Secretary, Homeland Security Secretary. We're still waiting to hear who the Health and Human Services Secretary will be. Obviously, there's been a lot of talk about Robert F. Kennedy Jr. We don't know if he will be the ultimate pick, or, if President-elect Trump will choose to slot him in, another role like head of FDA or CDC, or he could create a new role for him entirely, right? We've seen him appoint a border czar. So there's just a number of different ways that this could go. And the folks that we're talking to, both on the transition team and our health reporters, there is a lot of uncertainty about what exactly the structure of this team that will be making these health policy decisions will look like. But there are a few names that have been out there. So Paul Mango, the former deputy chief of staff at HHS during the Trump administration, has been leading a lot of this work on the health policy side. And then there have been a lot of these names that have come up in, conversations our reporters have been having with folks. And again, this could be sort of for any position. We've heard Dr. Jay Bhattacharya's name come up. We've heard Dr. Joseph Ladapo, Florida's Surgeon General, his name has come up. Some other folks as well. And so I think we're really just waiting to see what direction the president-elect chooses to go here. And honestly, that's going to have a really big impact on the direction that we see, the administration go on health policy, because President-elect Trump hasn't made this one of his top priorities, right? He's been focused on immigration and foreign policy, and his early appointments have really reflected that. I think the assumption is that a lot of this is going to be steered by whoever he puts in those top positions, and that's why all of our eyes are trained on who gets slotted into those positions. And I'll just say lastly, one of the things that we had heard was that from the Trump transition team was that this week was supposed to be focused on foreign policy and immigration. Again, you see the announcements that have been made over the last 48 hours reflect that. So the expectation would be that maybe we wouldn't get an announcement on a health secretary until next week. On the other hand, we got an EPA administrator announcement this week. So anything can happen, anything goes. So that's why we're all eyes waiting to see what will be coming down the pike.
Great. Thank you so much, Megan. Really appreciate those insights, and we'll have more discussion later. Mark, could you now please provide insights into how the election results might impact federal programs and academic public health benefits such as HHS, as Megan was talking about?
Sure. And I can't underscore enough what Megan just told us is it really is going to depend on who's in these key roles at HHS and the administration, is starting with this really kind of a wild card of RFK Jr. coming in, who is a kind of a non-traditional, I would say, person in the health arena that no one's really worked with before. But anyway, let me reset a little bit. So we just started yesterday the lame duck session of this Congress. It's coming to an end, and probably on December 20th when the current continuing resolution ends. And this morning, as Megan was pointing out, President-elect Trump had met with President Biden and also with Speaker Johnson, endorsing Speaker Johnson to be the speaker. What we didn't hear was what we were kind of hoping for is President Trump to say, we want the Congress to clear the decks. That would give Speaker Johnson the opportunity to finish the left open appropriations bills for FY25 that started on October 1st. We're under a continuing resolution, and there's a lot at play for schools of public health in that bill. We're looking at the House version versus the Senate version of like the labor HHS education appropriations bill. And so, the unknown is, are they going to try to finish this bill? If they do, they have to agree to a top line spending level first between the House and the Senate, and then they have to really sprint to get to the finish line to get this all done by December 20th. And if they don't, that means it all slips over into next year. A continuing resolution would probably run till the end of March, would be our guess. There's still an outlaw, possibility they would run it to the end of the fiscal year. That's been talked about. But what that means is then President Biden's gone. You lose the veto authority of having to stand up for probably more domestic discretionary spending than maybe President Trump would. And then the gavels would change in the Senate, of course, to Republican gavels chairing the committees, and the House stays the same probably as we're predicting right now. But for schools, specifically on programs, NIH had a big cut in the House bill. CDC took a big hit. They eliminated the entire National Center for Injury Prevention and Control with it, things that we care deeply about, like gun violence prevention research, the injury control research centers, prevention research centers were eliminated. Center for Forecasting was eliminated. The Agency for Healthcare Research and Quality was also eliminated in the House bill. We would expect all these things would be restored if this omnibus comes together by December 20th. I'm not worried that those would be eliminated now, but if this slips over into next year and then we have new players showing up like Elon Musk and Ramaswamy with a government efficiency committee, and they want to weigh in on government spending, I think we're into a whole different ball game that we've never really seen before. The other thing I would point out is that going on the Department of Education, of course, there's been proposals to maybe eliminate the Department of Education next year. We don't see that happening necessarily, but certainly the ending of probably student loan forgiveness is on the horizon. With the immigration reforms we're expecting, and deportation efforts, maybe there'll be new efforts on visas for our foreign students at which we welcome to this country. Maybe different level of scrutiny as to approving those visas we might see next year. Some of the other things kind of in the details of this conference that we're dealing with, going back, to the Office of Smoking and Health at CDC, which is a large office, $250 million is eliminated. That's still in play. And I think the other thing we're looking at is probably the end of an era for working on social terms of health equity, and health disparities as being something that President Biden strongly supported. There's not a lot of money left in the appropriations process to support those efforts. We've already had some resistance from Republicans on the Hill for funding proposals that President Biden put forward on that. But going into next year, that's going to be looked at with a different set of eyes, and and I think that's going to be a struggle to maintain some of those efforts. The other thing I want to mention in kind of closing, and climate and health, of course, is another one I should add to that list of things that are going to probably fall out of favor with the next administration. The last two things, that are kind of big threats, I think, on the horizon is the so-called Schedule F, where right now we have about 3,000 political appointees that get appointed to cabinet agencies. They're talking about changing the employment schedule, so people that have career civil service protections that have worked at agencies for 20 and 30 years at NIH and CDC might be subject to, basically kind of a Schedule C sort of ability to dismiss them and replace them. RFK Jr., for instance, has said he might want to replace 600 people at NIH, and so that's kind of an astounding number, frankly, where we get that. We don't have many political appointees at NIH beyond the director and the NCI director, so that would be a big change. The last thing is impoundment. Right now, when Congress appropriates money, you have to spend it on those purposes. There's a Supreme Court case going back to the Nixon era that says, kind of establishes that precedent. Some of the people that worked in the prior Trump administration as the OMB director and general counsel of OMB have said they want to question that authority, maybe test it in the courts. So meaning if we get an appropriations bill for FY25 and appropriates money for certain causes, they may come in the next administration and say, we're not going to spend it, we're going to impound it, we're going to go to court. So again, a new threat we've never really faced before. But with that, let me turn it back to Tim, and we'll hope to see you in the Q&A session. Thank you.
Thanks so much, Mark. Really appreciate your insights. Last but certainly not least is Dr. Khan. Could you speak a little bit about the implications for higher education, public health institutions, and the potential regulatory changes, and also give a bit of your perspective as a former CDC staffer who has seen many transitions? You're on mute, Ali.
Thank you, Tim, and for the opportunity to be here today. So that was a lot of questions. So let me take a little bite out of some of them, and then we can do the others during the Q&A. So I had 4 things I think I wanted to say. So the first thing is what I said to our students right after the election, which was, a quote from E.B. White: "Democracy is not a form of government, it's a way of life." And our collective commitment to public health and our values, it unites us beyond what our political differences may be. The second thing I want to say is that public health is and can be political, right? If you think about public health policy, politics matters a lot. Good politics, good science leads to good policy. We just need to be very careful, more so now than ever, that we're not partisan in the way that we're perceived, and especially since the American public, resoundingly embraced the Republican Party during the last set of elections, which would mean that the Democrats and some of those liberal values clearly are in a minority position here in the United States currently. When I look at schools and colleges of public health, there's currently 39 accredited colleges of public health and 77 accredited programs of public health in states that were swept by incoming President Trump. Now, I'm going to challenge anybody on this call to tell me that those 39 accredited schools and 77 accredited programs aren't doing a great job teaching their students and aren't having important impact, not just locally in their state, but many nationally and globally, right? So it is possible to do really good public health, even though you may be in a state that would be considered red. And so that's a reminder to everybody across the United States, right? No matter what state you're in, that you really can still do good public health. The third thing is, this isn't our first rodeo, right? We've already had one Trump administration, right? And for all of the concerns around the first Trump administration, at the end of the day, the decisions that were made about health were actually quite reasonable, right? So it was Secretary Azar, a lawyer, turned out to be a reasonable choice for Health and Human Services. It was Dr. Redfield, who turned out to be a reasonable enough choice for CDC. And nowhere, despite all the chants to fire Fauci, did President Trump fire Fauci during his 4 years, right? So at the end of the day, a reminder that for all the talk about, RFK and others, there may actually be a very reasonable individual who becomes the head of Department of Health and Human Services. So a name that I heard, and I'll defer to our other 2 speakers, is potentially Bobby Jindal coming in as head of HHS, who'd be a reasonable choice. I mean, he was a former governor. Megan and Mark would probably have more insights on that. And so, again, the rhetoric doesn't always translate into the execution, because at the end of the day, now it's not about getting votes, it's about running the country. And that's just a different calculus all of a sudden when you have to really run a country. Then I want to think about what is really going to be prioritized probably in this administration based on what we saw previously with the Trump administration, and then what we've seen in Project 2025 and other musings, random musings by many individuals. So my expectation is maternal child health will continue to be prioritized in a Republican-dominated executive, legislative bodies. Substance use disorder, obesity, chronic diseases, healthy aging, mental health, without a doubt, based on some of the legislation we saw at the end of the last Trump administration, rural health, and I actually personally I'm glad to be proven wrong on this. I think preparedness will remain a priority because if something was learned during the first Trump administration is you don't want your policy agenda sort of sabotaged by a pandemic. And I don't think the current administration would be anxious to have a new pandemic. And so I believe that there will be continued effort to make sure that there's strong public health to prevent another pandemic, which would then potentially, derail all of the public health, all the other stuff that the administration wants to do. But we'll see, time will tell if I'm right there. And then I want to end with some of the pieces of legislation. If we were start, Megan was talking about healthcare, right? So at the end of the Trump term, we knew that there were laws passed about parental leave. There was things around price transparency and the costs around drugs, and effort around tax breaks for caregivers. So there are pieces in there that are positive for us from public health. So let me just leave it at that, and looking forward to the next set of questions.
Thank you, Dr. Khan. I appreciate your optimism and hopeful outlook. So I'm going to ask a few questions, and then we will definitely get to the Q&A from the audience. I see it's coming in pretty strongly. So Megan, I want to start with you and ask you, what stories do you see on the horizon that you're going to be focused on with this new administration and new Congress?
Yeah, it's a great question. I mean, yeah, the first story I think is what we've all been talking about, which is what is the administration's priority on health? If it's RFK Jr., is it vaccines? Is it pandemic preparedness? Is it, I think we're all just waiting to see sort of what direction the administration takes. Like I mentioned, health reform broadly has come up. A lot of just still lingering frustrations with the Affordable Care Act. There's other areas which, might find more bipartisan support. What we've seen with drug price negotiations, right? That's an area where, we've seen both candidates talk about that on the campaign trail. When it was Joe Biden running, I mean, they both, claimed credit for that. And so I think that will be an interesting storyline to follow. And again, to the point of where can we find sort of bipartisan consensus and bipartisan movement, that's one where I would expect a little bit more of that. But yeah, so much, I mean, to the points that everyone has made, so much of this is going to depend on, who is in these roles and what their outlook is. If it is someone like RFK Jr., sort of his driving philosophy and driving concern is this, regulatory capture, right? That there's like too close of a relationship between industry and the people who are regulating them. And you will see that influence, whatever policies and bureaucratic decision making is happening. And it's kind of hard to know in some senses, like what plot lines we'll be following without knowing sort of who is going to be helming that. But those are some of the threads that I'm thinking through at this point.
Great. Thank you, Megan. Mark, I'll go to you, and I see some similar kinds of questions in the chat too, but given the outcome of the election, can you talk about what you think the policy priorities should be for academic public health going forward?
Yeah, sure. Thanks, Tim. I like Dr. Khan's list. I think I agree with everything he said, so I'm not going to repeat it. But I think part of so that's on the positive side of where we can work, and especially in preparedness, which he mentioned last. If and we do, I mean, again, going to Megan's comments with this unknown, I call them hidden moons of what RFK's influence will be if he's not the HHS secretary, but he's in the West Wing of the White House in an office where he's seeing the president almost on a daily basis. He might even have more influence than a cabinet secretary of HHS would, and and directing kind of his interests. And so, in that regard, we might be playing a little more defense if if he's questioning kind of the fundamentals of science and vaccine safety and the data, and he wants to see all the data on vaccines, then we might be playing sort of a defensive role and supportive and talking to members of Congress and to the administration about we look at the data too and we understand it, and we're experts in this, and so we have that role to play. If the former CDC director under Trump comes back, he's been close to, supposedly RFK Jr. and kind of the last few months, and he's been talking about H5N1 and preparedness, and he's been saying it's not a matter of if but when that breaks, and that could have higher mortality morbidity rates than COVID did. So we'll look to see if that becomes an alliance of some kind, if he comes into back. I don't know if he'd take the CDC role again. Usually people don't do that, repeat their jobs, but he could be in the ASH, or it could be some other Surgeon General job, and Bhattacharya is another one that kind of comes out of that movement that with RFK Jr. that again is he line up, and at CDC as a director, which he's on the list for that supposedly, and again kind of questioning vaccine safety. Do they take vaccine safety functions out of CDC and move them to FDA? That's been talked about. So the sort of reorganization of CDC, splitting it into two different agencies, where one's a data collection agency, one's a policy-making agency, all that is kind of in the offing. And then if you kind of lay over that, this threat of a Schedule F, where we're going to take a lot of career people that really understand the programs and understand the science and the data and have been involved in policymaking in the past. And we see droves of them retiring, which I think is a real concern and a possibility under a Schedule F. Then we have all kinds of new people show up and having to establish new relationships. So a lot, and then we want to certainly be in there with schools and our experts, kind of sharing our science and our understanding of it, to help keep the ship afloat, so to speak. Thanks.
Thanks so much, Mark. Dr. Khan, I'll just say it, you're in a red state, and you have been working very well with your school and there in Nebraska, and still advancing public health. Can you give our audience, many of whom are at schools and programs of public health, your perspective on how best to approach working with the new administration and making sure your priorities still continue to go forward?
Thank you, Tim. Yes, I'm not the only one. There's lots of colleges of public health in red states that are absolutely thriving, and doing great work, as I said, within their states. So a couple of thoughts. One is we can no longer be the invisible safety net, right? We used to pride ourselves on being the invisible safety net for health within our nation. And I think it's important for us as we train our students that they not be so invisible anymore. We need to think about what policy labs look like within our institutions, working with policymakers for real world solutions to the health issues within their communities. We here at the college, actually, we've started a series now, we will continue, which is training our students to think about how do they become policymakers, not just engage with policymakers. I think it's not just lawyers who can decide that they need to be senators and congressmen one day. I think that same thing's true for our public health students. More collaborations, business, law, political sciences across campuses, I think would be important moving forward, and making sure we're taking time to teach our students about advocacy, advocacy, ethics, leaderships. And so as we train our students with these skills, I think we'll be better placed in a future, in the current upcoming administration. And then broadly, remember, I think, at the end of the day, we're all scientists, and we should have a sense of curiosity about us. Why did over half of the American public decide that they were going to vote for these set of policy issues that are exemplified by the Republican Party? I mean, that for us should be about curiosity. Well, what is it, and what does that mean for us for public health, as opposed to disdain? I'm not, half of Americans are not, racist or sexist. That's absolutely untrue. If you look at some of the data, lots of people voted for reproductive rights while they voted for Trump, right? So I think as public health people, like in everything, we should approach this with curiosity, and And as long as we take that approach and think about that in the way we frame things, difficult things like DEI, without a doubt, will be a lot more difficult. Is how do we frame that? I think we'll be better served.
Great, thanks. So maybe one question for the whole panel, then I'll get to the Q&A. Given the increasing politicalization of public health, I see in some of the questions people are concerned about the impact on the workforce for public health, funding for research, and just generally the attack on public health. What can you all sort of give your perspective on that concern and what the implications are, but more importantly, how people can sort of be resilient in the face of this, I'll say it, attack on public health that we've seen?
I'm happy to start us off here. One of the things that I come back to when I think about, the politicization of public health is I wrote this story. So I cover politics now. I was covering the Harris campaign, Harris on the campaign trail, but my background is as a health reporter. So I really live at this nexus of politics and health policy. So actually a story I wrote, oh, no, I can't remember if it was this year or last year, but about what was going on in Indiana with public health funding, right? They managed to make this more than 200% increase in funding and local health department funding in Indiana after the pandemic, right? And this was so counter to a lot of what we're seeing around the country, where folks felt like they were really playing defense with their state legislatures. Indiana was just this really fascinating case. And I talked to so many Republican lawmakers, the Republican governor, Eric Holcomb. I talked to their former state health commissioner, Dr. Chris Fox, about how they managed to do this, right? Like, how do you get a massive increase in public health funding in this era where public health feels so political? People have all this lingering resentment toward how things were handled during COVID. And it was a couple of things. Like, one, and I think this is something that's like very possible at a state level, and maybe is slightly harder at a federal level, though still possible, is they had so many of those one-on-one conversations where Dr. Box and this one Republican state lawmaker would just go back to the member's office like time and time again and just have these conversations. What questions do you have? How can we answer them? And just really educating them on like what public health does, because they really found that I think there was this incorrect impression of like what it is that public health does. And so much of that was like these individual conversations where they actually were able to move the needle with individual lawmakers. And then the second part of it was really just being thoughtful about how they talk to folks about what they're doing, how they talked to the media, how they talk to these individual lawmakers. There are certain words that, for better or for worse, have become more political, like health equity. Maybe shouldn't be a political term, but some folks have that kind of knee-jerk reaction to it. And so, when I was talking to the folks there who got this funding increase pushed through, it was so much about like explaining what health equity is without using those words, right? They were talking about some of these disparities without sort of using the language that maybe folks are most comfortable using, but saying like, hey, look, we have these like rural counties or these parts in Indianapolis, and they're just struggling a lot more than the rest of the state, and that's a problem, and we need to do something about it. And so I think just being very careful about the language they used and trying to sort of figure out how to, speak the language of the folks that they were talking to. And I think what they found is that, again, when they, use that language, when they took the time, they found that people were more receptive to what they were trying to accomplish than maybe they initially had expected or anticipated. And I think also maybe there's like a bit of despair, about sort of the direction things are heading in terms of the public's attitude about public health. But, when I go back and I look at the numbers of support for vaccines, right? Like maybe there have been some dips since the pandemic, for instance, on political lines, when you look at folks' attitudes toward like the MMR vaccine. But if you look at the numbers, like the vast majority of Americans still believe in vaccines, vaccinate their children, all those kinds of things. So I think that like, as bleak as, when I talk to public health folks, as bleak as sometimes people seem or express to me, I think that there is this like growing recognition that there is common ground that can be found, and that it doesn't have to be political.
Well, if I can
Yeah,
extend that, Megan, that was excellent. So I try to say I'm careful about political versus partisan, right? Public health is political. It always is political because most of what we do is about policy change, and policy change is political. What concerns me more is partisan, right? And I think it's important for us not to be partisan in our approach because that's not how we approach communities. That's not how we approach patients for those who are clinicians, right? We don't care if you're progressive or liberal. We want you to be healthy, right? Regardless. And I think that's where public health gets in trouble is when it's perceived as partisan. And unfortunately, you're right. There are a couple of these trigger words now that public health needs to be careful of because in the current environment, those assume you are with a specific political party or not. But if you try to stay nonpartisan and talk about the critical issues within communities, people care about their families, they care about their kids, they care about their environment, right? And at the end of the day, if you can have the right conversation, the way Megan has outlined, you can still do good public health. And again, public health, what happens at the federal level is important. I won't deny that, but public health is very local, right? We're states. We're schools and colleges of public health in states, right? And that's where public health happens, in the states, in the localities, and that's where we need to be having these conversations to make sure we have the continued support, what we need to do. I'll give you an example. Red State, as Tim said, we had unanimous approval in the legislature for a safe syringe bill, right? Because they recognized that these issues were important in rural counties, not just in urban counties. And so, regardless of political affiliation, even though we're supposed to be a nonpartisan unicameral, everybody was, for the most part, was like, absolutely, let's get a safe syringe bill passed. And in the end, it was vetoed by the governor, but it's another story in itself. But if you have the right set of conversations with the right set of words, you can help people understand how important public health is every day to their lives.
Well said. Mark, did you want to add?
Yeah, I'll try to be short, but if we kind of go back in the time machine to 2019 and prior years, there's a lot of Republican support for the core functions of public health, and going through the list again of Dr. Khan's, maternal child health, maternal mortality, mental health, rural health, preparedness, substance use disorder, opioids. Some of those things were led by Republicans, and now that they own it, they own public health. I think hopefully we've turned the corner on the COVID era, and they have to have ownership. They have the White House, the House, the Senate. They're going to control the agencies. So I think we're kind of past that point of we came out of COVID and we had Dr. Walensky at CDC, for example, followed by Mandy Cohen. They had to kind of still apologize. And when we talked on the Hill to Republicans, what do you want? To kind of like public health again. They want accountability and transparency. Those are the things we kept hearing over and over. We want to see some reform. Okay, now the ball's in your court. You control everything. So the burden's on you, and we want to be partners. We want to be your academic partners. We understand the science better than anyone. I mean, not that we don't respect public health departments and the governmental health the role of the health departments serve, but we are the ones that develop the science, the evidence base, and we hear evidence-based science over and over. And Republicans, when they write legislation, that's what they want to lead with and they want to see. So I think there's a lot we can work with and just move into a new era. Thanks.
Great, thank you. So I'm going to go to the Q&A from the audience. Suzanne Lazarick, sorry if I pronounced that wrong, is asking about Project 2025 and is hopeful that maybe this administration won't be implementing Project 2025 in the way some had feared related to public health. Can you talk about that? I'll start with you, Megan.
Yeah. A couple of things here. I mean, one, we have seen and are seeing more inklings of this, that some of the folks who are part of Project 2025 are trying to get into the Trump administration or under consideration. So I think we heard that there was this total blacklist, and it's not at this point turning out that way. So I don't think we can rule out that folks that were involved in the creation of that document won't be involved in the Trump administration. And I feel like I'm a broken record, but so much of this does go back to who are in those positions. If we see if we see some of the names from the health world that helped create that document in positions of power, we probably will see some of those policies at least be brought forward. But I think so much of it, just depend. We just don't know what direction we're going to see this country go in really on some of those policies.
I mean, you can't help that, Megan. It's until we know more, we can't say. That's it's still good to get your impression. Mark, did you have anything to
Yeah,
add?
again, we have some late breaking news during this call. Thune was elected the majority leader, 29-24.
Interesting.
And playing into what Megan was just saying, why is that important? Because Senator Scott, who was also running along with Cornyn for the job, Scott had said, I'm going to be for what President-elect Trump wants to do, which is let the Senate recess, and I'll have recess appointments. They don't have to go through the Senate nomination confirmation process. So with Thune, we expect him to be institutionalist. He has not taken that pledge. It doesn't mean he won't do this, but I mean that, if you want to have some safeguards and guardrails around making sure that we have, at least the ability to question people's policies before they take over the head of NIH and CDC and other agencies, that we have that process potentially in front of us. There will be a nominating process with a Senate confirmation and Senate hearings. So I think that allows you to vet, Prop 2025, and I'm sure, Democrats will be holding up chapters of that book saying, is this what you intend to do? And then they'll have a vote. Doesn't mean that Republicans aren't going to, with majority, because they don't need 60 votes. They only need, the majority vote to, confirm these people. But at least you have a chance to question people and get commitments on the record about that. So.
Thanks. Did you have anything to add, Ollie, or should we keep going? Okay,
Well
great.
said.
So Ashta Ramallah, hope I say this right, is asking about the NIH and the outlook for the NIH, and the discussion that has happened on the Hill around consolidation. Mark, I'll turn to you on that.
Yeah, I think consolidation is certainly possible. It would require a reauthorization bill to go through the Energy and Commerce and Health committees. Right now the gavel's a little uncertain as to who's going to control either Guthrie or Lot, the chair on Energy and Commerce, and then help will probably be Senator Cassidy. But the House appropriations bill I referenced earlier, it actually did restructure. They kind of jumped the gun a little bit ahead of the authorizers and did restructure NIH a little bit. But I think that's definitely on the table. Even going back to Dr. Varmus, back during the Clinton years, said that we had too many ICs, and I think about 27 or so. And I think he was proposing a time going down to 4, 5, or 6. I can't remember the number, but just this
7,
idea.
yeah.
Okay, thanks. Thanks for the reminder. That this is something that should be done. But the backstop to that is the disease groups that want to have the identity of their own center, and we'll go to Congress and try to probably oppose that. But
okay, good.
Tim, I think the bigger issue isn't a reorganization. People love to reorganize. And as we know, there's no perfect organization. I think the real issue is money, right? And what happens to the resources and the priority setting, right? That's much more important than what boxes that falls in. And fortunately, NIH has a lot of support at state levels, right? Because it's a lot. I mean, that is the money that's coming into universities, and the state and their congressional delegations know that. And the universities make it very clear to their congressional delegations what NIH money means to them. So I think the bigger issue for NIH is what's really going to happen in funding and priorities.
Yeah, exactly. Megan, do you have anything to say, or should we move on? Okay. Thanks. So there's a question here, anonymous question about people worrying about their refugee clients, folks that they work with who are refugees, and the impact, related to infectious diseases. This has obviously been a huge topic of the campaign trail. So if we could talk a little bit about immigration and the impact of public health, especially as it relates to refugees, that would be great.
Well, I'll start on that in terms from the health aspect and public health aspect to make sure that we're, as part of our missions, that we're addressing the needs within those communities, and what, from a science base, what it looks like we should be doing for those communities. I know already do. I know we do here. We work with refugees all the time. Since Nebraska, despite its size, our per capita actually takes, I believe, the most refugees of any state in the union. And that generosity, remember, a red state, in a red state. As far as the political ramifications of, we're going to round up a whole bunch of so-called undocumented immigrants and send them out of the country. I'm going to leave that to Mark and Megan to say what does that what does that potentially look like? But rural populations, refugee populations, I mean, this is the diversity that I like to talk about and diversity of opinion that I like to talk about. And it's not just about gender and sex and race or ethnicity, right? We need to think more broadly about our communities and how do we help meet their needs and how policy makers understand why this is so important to make sure that we're meeting the needs of these communities.
Yeah, it's a tough question. I mean, we've kind of went through this with COVID a little bit, touching on, providing health services to, people who maybe are here undocumented. And I think, the bottom line is we ended up doing it. But then we had a difference between Trump and the Biden administrations. They used Title 42 authority to, kind of tell folks that were coming here, presenting themselves, coming across the border, seeking asylum to say, we're not going to, because of the health emergency, we're not going to let you go through the asylum process. We're going to send you back. And so I've already heard, incoming Deputy Chief of Staff Stephen Miller saying we're going to bring back Title 42 and use it in some way as a tool. So it's not really responding to your question, so to speak, but it's definitely in play about how do you look at this immigrant population and do they have kind of access to healthcare services and can a health department vaccinate people that are here? If there's another outbreak, and we went through this with we did it through with H1N1 back in 2009, and again with COVID. Just as do health departments have to prove that they're here as a documented, legal person here before we can give you health services like a vaccination. I think we ended up vaccinating people, but see, people do, I think this is a little different when you start talking about deporting 10 million people. I think people would be afraid to show up at health departments for fear of, for any kind of health services, for fear of they're going to be rounded up, deported, or their family members will be, if they're not here legally, might be touched by it. And when they start taking names and that, and so I'm going through, back in the day when we did H1N1 in 2009 again, it was, maybe we would have churches be a safe place to go get vaccines because people wouldn't come to health departments. So we may be back into that era of like, where are safe places for people, an immigrant population, especially those who are here without legal status, to seek health services from the public health community, the providers.
Can I add to that a little bit? I mean, comes back to political realities, right? So I'm thinking about H5N1 right now, and we think about all of these people who are working on these poultry farms, many of these individuals who are working in these dairy farms, 80% speak Spanish. A significant proportion of them may well be labeled as undocumented, right? We're not letting those people go. Right? You can probably, I've been told chickens, you can maybe wait a couple of days to feed them and water them, but you better milk those cows twice a day, right? That's just gotta happen, right?
Yep.
This was the same thing with the abattoirs, the meatpacking plants during COVID-19, right? It was how do we make sure? I mean, they were actually called essential infrastructure, that we must make sure that those run. So again, there's campaign rhetoric, and then there's the realities of governing, right? And as Megan keeps saying, it depends on who the individuals will be who will take those leadership positions. But at the end of the day, they're going to have to govern. And it's not like there's these 10 million illegal or undocumented aliens who aren't doing anything. I mean, they're part of the economy, right? And there are consequences of making radical decisions on how we deal with these individuals.
To Dr. Khan's point, I would just add that there's a lot of, I think, like different factors tugging at each other here. There's the economic realities. When I was in Arizona reporting during the campaign, right, there are a lot of like genuine frustrations about the border. I was talking to Representative Cuellar in Texas, represents a border district, and he's a Democrat, but he was telling me like he won re-election as a Democrat, even when all, these three counties went for Trump, because folks were really frustrated about what they saw as, a not strict enough border policy or what have you. And he said that they were frustrated that they felt like folks were getting, economic help, lodging help, healthcare help that they themselves weren't getting. So you have on one hand, that's going to be sort of tugging at the Trump administration, sort of those underlying concerns and everything that, the president-elect has been running on since 2015. But at the same time, to Dr. Khan's point, these economic realities of what do you do with the fact that these folks are major drivers of our economy. And that's a bigger question for someone else to answer, but it's certainly going to be something to keep an eye on.
And my Republican friends are all in favor of legal immigration. I mean, I never hear from any of my friends that they're not in favor of legal immigration.
Yeah. Okay, great. So, going back a little bit to academic public health, Mary White asks about the lessons we might learn. She goes back even to the Reagan administration and the first Trump administration in terms of the messaging that academic public health may not have done so well at in terms of working with those administrations. What are some lessons, Mark? I'm going to start with you that we can learn about our past work in public policy related to academic public health?
Well, I think we've done a pretty good job, frankly, in explaining ourselves in public health. If anything, I don't know, with outcome of the elections, I wouldn't say this is something, that people have voted for Trump's policies here, so to speak, and they voted for, anti-DEI and anti-health equity. We have people at our, firm that were, someone who's I've been speaking, last couple of days here on these sorts of panels, and he was the former chief of staff to the RNC, the Republican National Committee. And the way he looks at, the election outcomes was not so much people voting for the Trump policies or 2025, but really it was something as simple as right track, wrong track. 65% of the country said we were on the wrong track for whatever their reasons, whether, it was relative to immigration, gas prices, grocery prices, mortgage interest rates, whatever. And, Vice President Harris was just part of the Biden administration. And, she, said, I don't see anything different. Her first answer was, I don't see anything different I would do. And then she later tried to, establish some room between their shoulders and saying, well, I do something a little bit differently here and there, but I think that stuck. And I think that, so, I don't think this was, people are voting against, our efforts to do health equity, which is something that ASPPH has been committed to for over 20 years that I've been working with, the ASPPH as an organization as your outside consultant lobbyist. So I think, I wouldn't, say that I think, Megan kind of hit on it. You have to talk about something like health equity in maybe a little different terms. When we talk about, in terms of, racism, that's a turnoff to people. When you talk about equity, to some people, not to all. Many people understand that is the root causes of some of the disparities in this country. But, for others, it might be rural health, inequities, that are different, not just African American and Hispanic populations in API, but also in white populations. And I think that's something I think we can do better when we talk about equity, and it's people that don't have access to transportation, food, insecurity, mental health services, regardless of race and ethnicity. And I think that's something we could probably, say that's really what we're trying to get at. But even though we can identify that, yes, if you do the overlay race and ethnicity, you can see these populations stick out, quite a bit, and added Native American populations at the top of the list. So I think there's a, kind of a way to recast and respin how we talk about SDOH equity and DEI in a way that's, really getting at what we're trying to get at, which is improving the health outcomes for everybody.
And it was during the Reagan era that we had C. Everett Koop, come out with the HIV prevention message into everybody's mailbox. So I think it's important to remember that science always wins and truth will always win at the end of the day, right? Climate change isn't going to go away for the next 4 years just because people don't want to believe in it, right? Certain things don't need belief, they exist. The other thing is to remember that we're not the opposition, right? It doesn't matter to us what political party it is. How are we partners with whoever the administration is at the state, local, and national level to do the work that we want to do that holds true to our values, right? Which is, if we don't want to call it health equity, preventing health disparities within our communities, right? So everybody, rural, Black, brown, whatever you are, to make sure that you have an equal opportunity for health. So maybe some of the language changes a little bit, but I don't think in any of this our values change. And as I said before, it's not as if somehow there's a half of this country that doesn't care about their mom, dad, their son, their daughter, and their grandparents. I mean, they do, of course they do, and their environment. If you think about the biggest environmental gains that have been made in this country have been under Republican administrations. So I think we just need to remember that we're not the opposition here, right? We are partners, academic partners with whatever administration there is to advance health for everybody within our nation.
Wonderful, yeah. Anything to add there, Megan? Okay. Um, Mark, we had a clarification question. Some people aren't understanding the Schedule F piece. Can you just
Sure.
spell that out
Yeah.
a little bit more?
Yeah, sure. So usually when people work for the federal government, there's kind of two basic classifications. One is you're under kind of Title V, civil service protections. Means you can't just can't just fire somebody, for without cause. So you have to go through a whole process. And then there's Schedule C, where you bring in political appointees that don't go through the Office of Personnel Management, OPM, insert lists, and you're making sure you qualify for a job. You're just political. You come in, and then you serve at the pleasure of whoever the boss is, and they can fire you tomorrow, just like working on the Hill. You're hired and fired, kind of at will. And so right now we have about 3,000, I think, we call plum book or Schedule C jobs that are the political jobs. And usually there are CDC, there's maybe two or three, NIH has two or three, but there's not a lot in the public health service in general. There's a lot, over at HHS. But what they're talking about is, converting those, anyone in that kind of policy-making job into a new Schedule F. And it was actually proposed, you can Google it and find it. It was in the Federal Register in the last, I think, October of the last year of the Trump administration. They actually published it. They didn't have a chance to really implement it. And so under Schedule F, they were going to convert people in a policy-making role, which is a lot of people, into a new classification where they can fire someone who's in that role, who's under current, civil service protections, and replace them with someone else who's more, I would say passes the loyalty test is what they're calling it, to the Trump administration. And so I think you could see, places like a CDC, where people, I think a lot of people on the call are familiar with, we have centers and divisions. You can have people at lower levels of CDC, in the center director's job and division director jobs being more essentially a political job, that someone who's going to be more or less loyal to the goals of the Trump administration, and not someone who's been at CDC for 20 or 30 years. And I threw out a number earlier that I heard RFK Jr. in an X post or something saying that he's talked about 600 people at NIH. That's a lot, of people. And I don't know how you even arrive at a number of 600 people at NIH, unless it's, just like the entire vaccine, everyone working on vaccines gets, is that the head count or the FTE number for that? I don't know where that is, but that's what it means. And so I think that means that a lot of people that are in these policy roles, which are all the senior people, are now, thinking like, gosh, is it time for me to retire? And you could see a very big turnover of people that we've all worked with for decades, saying it's time to retire, or it may take a year or two. But if this actually does get implemented in a way and they bring in kind of loyalists, so to speak, you'll see a big change in how government operates, I think.
Thanks,
It kind of
Mark.
breaks up what it would call, if some of the students of political science, like the iron triangle, the people that have the Hill relationship and work in the agencies, and the political people come in and go, and they can't really affect change because the career people are going to kind of wait them out. The Trump administration has gone through this for 4 years, and they figured out, oh, I see the obstacle is they're actually the career people. And so that's kind of what they're gunning for.
Exactly. Yeah. So we have a couple of questions about data and the concern about preserving longitudinal data, archived data. One person says that they saw in Florida that there was real concerns about factual information being scrubbed by a new administration. I'm curious what you think about the need for protecting data.
That may be a state by state issue. I can tell you here in Nebraska, we've not had that. I mean, our COVID dashboard went away, but so did COVID dashboards across the United States. But there's new regulations in place about reporting what's happening within hospitals, and we've actually seen some new dashboards come on board around maternal child health recently in the last couple of weeks to provide additional data. But data is the lifeblood of public health, and we need to make sure that's one of the skills we teach our students. How to analyze and visualize and report data and support data. So I mean, again, state by state, there may be these issues. I'm not sure what the specific issue is in Florida, but we need to stay true to data. I mean, that's who we are as colleges of public health.
I think they're asking at the federal level, though, about the preservation of long-term data. Mark, did you want to jump in?
Yeah, I don't see that as a big threat. I've not heard that. I think if anything, it's, we've heard Republicans saying that they're for data and they want more transparency and they want to see the data, maybe have different people analyze it and review it. So that was the whole knock against CDC is they collect the data, but they don't share it. And then they make policy on the basis of that. So if anything, I would see data, especially these longitudinal data sets like NHANES and substance use surveys that are done at SAMHSA. Those are, big data sets that have been around for decades that you would hopefully we'd preserve. BRFSS is another one at CDC. So I'm not heard anyone kind of questioning it. But I think that's hopefully that's something that's not, we don't need to like download it all and preserve it, and have it in our university servers. I think it's going to be okay.
Okay.
And I
Yeah.
would agree with you, Mark, that this push for data transparency may actually provide opportunities for colleges of public health to access federal data that they currently don't have access to for analysis purposes and insights.
Yeah, and I think one thought, if I can take a PS on this, with the advent of AI and the ability to analyze big data sets and compare, big data sets, the CMS data with, CDC public health data, is just going to be, I think, transformative in a way. It's really going to advance the science of public health. So I would hope that that resource, not be, taken away.
Well, I'm sorry that the hour is up and I lost track of time because I could ask questions all day long, and obviously the audience wanted to ask a lot of questions. And I'm sorry we didn't get to them all, but thank you all so much for being on this panel and for your excellent insights. I thought it was a great discussion. We will be making this available so you can use this QR code that's being shown to download this and watch it later if you haven't seen it this time right live. But thank you, Mark. Thank you, Megan. Thank you, Dr. Khan. We can't thank you enough for your helpful insights, and we'll all be prepared to continue to advocate for academic public health going forward. Thank you. Take care.
Thank you, everybody.